I think to think about what are new drugs kind of in testing in RCC. I mean, there's a handful of agents. There's a novel TKI called XL092 that's currently in testing in the Stellar 1 and Stellar 2 studies in combination with IO. There's we saw the very excellent data presented from the Zircon study of using PET imaging for detection of localized RCC, kind of small renal masses. And there's actually a radioligand therapy targeting CA9 called girentuximab that is also in testing in the Starlight 1 and Starlight 2 studies that I think holds promise. There's a handful of HIF inhibitors. Belzutifan is probably the one that's closest to market, but there are others that are also being tested to look out for. There's antibody drug conjugates that are being developed. Daiichi Sankyo's got an ADC that's being looked at in RCC and ovarian cancer. So, there's a lot of interesting studies. There's next generation CTLA-4 inhibitors that are also Treg depleters that have demonstrated efficacy that are being looked at in kidney cancer. So there's a lot out there that I think we all need to be, looking out for and optimistic about. I mean, I think the biggest thing is where does triple therapy lay in the frontline setting? We saw data from Nivo Ipi-Cabo presented at ESMO this past fall. I think the study was a positive trial. It met its primary endpoint of improved PFS, but there's still a lot of questions to be had about toxicity, safety, what's the benefit with regards to overall survival. There's another triple regimen that's being tested, looking at the backbone of Len-Pem, but also adding belzutifan and CTLA-4 inhibition to that backbone. So I think that'll also be informative. So, we're looking at how do we escalate therapies. And while we're focusing here the discussion on advanced RCC, there's also been great progress in the localized setting with adjuvant pembrolizumab being approved, and now also adjuvant pembrolizumab plus belzutifan being tested in a phase 3 trial. And whether somebody received adjuvant immunotherapy is certainly going to impact what they end up receiving or what they would respond to in the metastatic setting. So I think that's going to also play into the treatment sequencing in RCC.